Okay, good afternoon. We have to talk about the multiligamentous reconstruction in single or staged procedure. I have to talk about the single stage, but in reality, the patient selection is too important. And I talk about the multiple ligamentous reconstruction in same stage, but in reality, I'm not serious in this topic in my mind. We have to know completely, we have to completely classify the patient as the patient is acute or chronic, and the knee dislocation is a high energy knee dislocation or low energy dislocation. Because if there is a severe bone bruise, intra-articular cytokine increase significantly, and risk of future arthrosis increase. And also in high energy knee dislocation, severe bone bruise may cause osteonecrosis in the future. So these problems affect on your decision making. Low energy knee dislocation has improved better outcome, but in Tegner activity score, but in Lish-Holm IKDC and failure rate between low and high energy mechanism, there is no difference. I do single stage multiple ligamentous reconstruction, but I have answer to the questions why I do it, and when I do it, and how I do it. My goal is to have anatomical reduction, full range of motion, pain-free, walking and stably. Single stage has less mental, physical, and financial burden on the patient. It's true, but you can't do it single stage multiple ligamentous reconstruction with appropriate rehabilitation. You have better outcome. And also, if you do it with good physiotherapy, risk of graft failure and infection or additional injury between a staged procedure decrease significantly. And there is similar risk for arthrofibrosis, DVT, and wound complication between single and staged procedure. So, I prefer single stage. When in the acute phase, I do single stage if there is avulsion, like the previous talk, avulsion repair, and same stage reconstruction. And in the chronic stage, I do all together. We have to have plan about the graft source, about the tunnel creation to prevent tunnel convergence for the femoral and tibial. I explain you why, and graft fixation also. To prevent tunnel convergence in the medial side, for the MCL reconstruction, you have to create MCL tunnel in 30-degree coronal and 30-degree axial angulation, and for the LCL, 40-degree in the angulation anteriorly too. Order is tunnel fixation and order of tunnel creation is too important. Order of tunnel creation is femoral tunnel, ACL and PCL, tibial, then tibial tunnel, ACL and PCL, MCL and LCL finally. But this is the problem of single stage multiple ligamentous reconstruction. This is my patient. I do ACL, PCL, MCL double bundle MCL reconstruction, LAPRADE. The patient was very well. After 2 months, due to car accident, motor car accident, the patient came to me with this picture again. Be aware, the risk of pathologic fracture increase with single stage reconstruction, like this. I operated the patient, but fortunately the ligamentous was intact. We have to now order of tunnel fixation. Femoral first, femoral PCL, ACL, then tibial PCL, MCL, NCL, and tibial ACL finally. We have contraindication for single stage that my colleague explained to you. I prefer, again, single stage if there is indication for my patient, but be honest with yourself. Good stages procedure has same functional result on this also. I prefer single stage, but it depends to your ability, your setup, and your patient selection, but not to be rigid.
Okay.